All right, how's that? Can you guys hear me now? There we go. I see my audio going up and down, so I think that you can hear me now. All right, amazing. Okay, I was talking before, but you can hear me. So welcome. Welcome to our first of 2026 In the Know with knownwell. I'm Dr. Angela Fitch. I am the co-founder and chief medical officer of knownwell, and I'm here in Boston, Massachusetts. We just got about 2 feet of snow over the past 48 hours or so. So we're hunkered down here in a snowy winter wonderland. And so if you are too, I'm with you there. I'm feeling it. So we are going to talk today, and I'll just remind everybody to if you have uh, questions, you can certainly put them in the chat. It's hard for me to sort of see them in the chat, but there's also the Q&A. So I guess there's a Q&A section. I forgot about that in the webinar. So please put any questions that you have in the Q&A channel, not the chat channel. If we could keep it in the Q&A, that would be great. And that way we can I can go through those at the end. It'll be hard to sort of see those as we're going, but we'll certainly address them as we go through the webinar at the end. All right, so we're going to cover, some information about the Wegovy pill, as a lot of people have noticed. Um, just going to turn off my little heater there. So the Wegovy pill has made a lot of a big entrance here in January 2026. So we're going to learn about what is that all about? What is the new Wegovy pill? How does it work? What are the side effects, the outcomes? We'll talk about some treatment options when maybe you don't have coverage for medication for obesity treatment. We know that there's been a lot of changes recently, and a lot of people have lost access to coverage for obesity treatment. We'll talk about, if you do still have coverage, that's great, good for you by your insurance. But if you don't, there may be some treatment options for you that could be affordable. And then we'll talk about how we can help at knownwell. So what we can do to help you along if you're looking for help in this day and age. So first, to sort of level set things, obesity is a chronic treatable disease. If you look at the definition here of obesity, obesity is a disease in which excess body fat has accumulated in a dysfunctional manner to a level that may have an adverse effect on health. So all of those things in the red are very important, right? It is not, nowhere do you see in this definition anyone talking about a number on the scale or talking about weight, right? It's really about our excess adiposity. Adiposity is the fancy word for excess body fat. And the fact that this is accumulating in a dysfunctional manner means it's not your fault. It's not a person's fault that it's accumulating. It's dysfunctional. You don't want it to accumulate this way, but this is what's happening. And it may or may not have an adverse effect on your health. And we should recognize that together in a clinical relationship that maybe it's affecting your health, maybe it's not. And so we should also embrace that if it's not affecting your health and recognize that that's what's going on. It's the only disease, obesity, in the US that's not a standard essential health benefit. So this is one of the reasons why we have such variable coverage by insurance, because it's not mandated by your insurance to cover obesity. It's not something that has to be covered. And because of that, there's been and because of the cost of treatment of medications, employers are having to choose whether to add coverage or not, and that can be very challenging. It's also the only disease where we require it to show cost effectiveness before we as a society agree to treat it. And that's another problem we have nationally, is to say that, it has to be cost effective before we offer treatment. That's something that we don't do for other diseases. There's a lot of diseases that we treat in medicine that cost a lot of money and don't actually save money in the long run. We actually have some treatment of obesity where it actually does save money. It saves about $3,000 per person the first year of treatment. That's how much you're expected to save in terms of healthcare spending throughout that first year just by treating obesity. So there is a cost savings. It's just that the cost to treat it is not something that it's not at the level where the savings is adding up at the moment. So, but in the future, we expect that to change. That's the hope. And if you have obesity, you have to understand it's not your fault. This is a disease like other diseases. The majority of the disease is actually interestingly, dictated by genetics, by biology, by epigenetics, by what happened when people are in utero in the womb, right? If you look at weight as a thermostat in this analogy here, and how does that thermostat get set, or how does that thermostat change? Well, there's several factors beyond genetics. There's our processed diets. There's irregular eating patterns that we have in the world around us. There's ultra processed food. There's inadequate physical activity. We just don't move as much as we used to. I've been sitting here for the better part of the day. And so again, making sure that we're trying to make changes there is a good thing for our health. And we should do that for the health of it, not necessarily just the weight of it. Inadequate sleep. Sleep affects our metabolism. If we don't sleep well for whatever reason, that can also increase our weight. Stress. There's a lot of stress right now in the world. A lot of stress, as we know. We all know from the events that have happened recently or continue to happen. Lots of stress going on. That also can play a role in terms of our weight and our weight management. And then weight increasing medications. There are medications that actually increase our weight, right? And so it makes it harder for us to lose weight. And we want to recognize that and we try to manage that. We try to help patients manage those medications in the long run. And then there are life changes that we can't change at this point. There's aging, there's pregnancy, there's menopause for women. And those life changes promote more fat storage by nature. And so again, we're kind of fighting against that biology of ours. And all these things serve a purpose to sort of ramp up that set point on that thermostat, right? And make it harder for us to go the other direction. And why is that? Well, it's hard to go the other direction because weight loss is not normal. It is not normal to lose weight. This is from the rethinkobesity.com website. You can go there, you can learn more about obesity, more about the things we're talking about right here, is that lifestyle interventions alone are often not enough for treatment of obesity because of this pattern here. What we see is when we as humans try to lose weight, we maybe decrease our calories, we increase our physical activity, that weight, that tug on that rope tends to go in that weight loss direction. Unfortunately, our body fights back in the other way because our body is naturally inclined to gain weight. It doesn't want us to lose weight. So our body slows our metabolism and increases our hunger hormones. It decreases our fullness hormones, right? One of those fullness hormones are GLP-1, and it decreases that fullness hormone. Our body decreases our natural GLP-1 so that we don't, because it wants us to gain that weight back. It wants us to put it back on. So we need help, right? We need help with medications, with procedures, with surgery, with other types of interventions in order to have another pull on that other side of the tug of war. And that's what we're going to talk about today. So let's start by just talking a bit about GLP-1 in general. What is GLP-1, right? That's the new Wegovy pill is an oral version of Wegovy, and Wegovy is a GLP-1 agonist. It activates GLP-1 in our body, our GLP-1 receptors. The GLP-1 was first found with the Gila monster here. So from going from lizards to extending life, meaning, the lizards are the ones that sort of use this to their own advantage. The Gila monster eats only 4 times a year and is able to turn its pancreas on and off. It does that by working on its manipulating its GLP-1 levels. And this is where this came from, right? Way back in the day, and we'll talk about that in a second. The first GLP-1 receptor agonist, exenatide, was around all the way in 2005. So these medications, GLP-1 agonists, have been around for 20 years. And I wanted to put that in there because I wanted people to understand this isn't necessarily something, new that we're experimenting with. This has been around for a long time. The Gila monster, at the time when exenatide was created, it was initially isolated from the saliva of this Gila monster. It was only 53% as similar to our own GLP-1. So again, because it was like a lizard's, GLP-1, it wasn't exactly like us, right? It was only 50% as similar to us. What happened and what made semaglutide so different when it came out in 2017? So semaglutide as a drug was released was FDA approved in 2017. And what was so different about it was it's 94% similar to our own GLP-1. So because it's so similar to our own GLP-1, that's one of the reasons why it works so effectively compared to other treatments, and why it sort of became so known within everybody saying, why is it that everybody's talking about Ozempic? Well, that's because semaglutide as Ozempic was first available in around 2017, and it was so similar to our own that that's why it had greater efficacy than some of the older medications. And this just shows you all the what's happened over the years, right? This research around GLP-1 first started back even in 1964, right? Or even back as far as 1906, when they recognized that these duodenal extracts, these incretins that stimulated internal pancreas secretions, existed in the first place. They didn't know what to call them. But then you can see this timeline of research. And I just show this because this is how long it has taken to really put all of this effort into understanding this biology. This just didn't happen overnight. And because of that, we really now understand much more about how GLP-1 receptor agonists work and why they work in our bodies to help us. This shows where these GLP-1 receptor agonists work. And here you have in the red, this is GLP-1, stands for glucagon-like peptide 1 receptor agonism. These are all the things that the GLP-1 activation of that GLP-1 does, okay? And then on the green side here, this is called glucose-dependent insulinotropic polypeptide receptor agonism. That's short for GIP. So GIP is another incretin, right? And we now have medications such as tirzepatide or Zepbound that works on both of these, that activates both of these receptors. So Wegovy or semaglutide or Ozempic, same thing, all of those things, they activate GLP-1 receptors. Tirzepatide, which is another product now on the market as Zepbound or Mounjaro, it activates both GLP-1 and GIP. And you can just see here all of the things that this activation does for us. It increases our satiety, decreases our food intake, decreases that food noise that everybody's talking about, right? It has changes in our pancreas. It decreases the emptying of our stomach, so our stomach doesn't empty as quickly, and therefore we feel fuller longer and faster. It has activation effects on our skeletal muscle, on our liver. So it helps us in many ways to improve our metabolism, so to speak. So this is the molecule semaglutide. This is what it looks like here in sort of 3 dimensions, and this is what it looks like here in 1 dimension. And it is a protein peptide molecule. A peptide is a short chain of 2 or more amino acids. These are each the amino acids, right? So we have all these little amino acids that are hooked together to form a peptide, which is essentially a protein, right? A protein molecule. So this is different than other drugs like blood pressure medications, drugs like aspirin you might take for a headache, or ibuprofen. They're really chemical drugs that do things within our body. This is actually a protein molecule or a peptide that activates a receptor that because of that activation then has positive benefits. So I say that just because it helps to understand, because this is a protein molecule and because it's so large as it relates versus a medication, it is harder to get it into the body, which is why these drugs were initially developed as injections, because it's hard to get them in the body. Semaglutide is available in many forms. So we have Ozempic, which was the first version of semaglutide that we talked about in 2017. This is semaglutide, and Ozempic is approved for type 2 diabetes. We then have Wegovy over here on the right-hand side in these individual each unit dose syringes, right? So 0.25, 0.51, 1.7, 2.4. These are the doses of Wegovy. So that Wegovy was approved for weight management. Same exact drug, semaglutide, in 2 different packages, but indicated for different things so that we can prescribe them differently within and keep track of them differently as it relates to coverage and insurance and other types of FDA approvals. And then here at the top is the new Wegovy pill. So now we have the same semaglutide that we saw before, that molecule that's now living in a pill that we can take by putting it into our stomach and getting it absorbed that way. And so again, it has multiple dose titrations in order to get up to the top dose. And we titrate the drug slowly to minimize the side effects. So the side effects of gastrointestinal side effects predominantly that we'll talk about in a little bit. So oral Wegovy, here you have the Wegovy that we talked about, right? But in order to get it into our stomach, instead of injecting it, they have to put it together with a molecule called SNAC, and that's a really long name for this long, sodium hydroxyl benzyl amino caprylate. So you have to say that 10 times fast before we get done with the seminar. But the SNAC molecule here sits on the side of the is connected to the semaglutide molecule itself, and then it goes into the stomach. It has to sit against the stomach wall, and then that SNAC serves a purpose. It's an absorption enhancer. It protects the fragile peptide from the stomach acid and enzymes. Because peptides are proteins. Our stomach is designed to break down proteins because we eat protein, right? And so again, because it's designed to break it down, you would just take this in and it would just break it down. That's why some of the things that are being sold off market or in the compounded market today really are not working. You're being sold something that potentially doesn't work because it doesn't have that SNAC molecule attached to it, right? It's very important that this is attached. That SNAC also neutralizes the pH locally, so the pill goes into your stomach, that the acid around the pill is neutralized, and then it creates it makes the membrane of your stomach temporarily permeable so that that can get absorbed. You can see that here in that lumen of your stomach, right? It's making it so that that molecule can get across that wall of your stomach and into your bloodstream. And that's very important. And we'll talk about that later as to why that's important, as to how we take the medication and how we prescribe it. So this is just a slide to show you that there are multiple clinical trial programs that have been done on semaglutide in particular. And in fact, as far as for oral semaglutide, this is just oral semaglutide. There's many more clinical trials on injection semaglutide, and those are all called STEP trials. So these trials all have names to them. So the weight management trials of injection semaglutide is called STEP trials. The trials around oral semaglutide for diabetes are called the Pioneer trials. And so those are all trials, 1 through 10 of them, so 10 randomized controlled trials of patients taking oral semaglutide for diabetes. It is a different drug. It's called Rybelsus. It comes in different strengths. It comes in 3, 7, and 14. So it's important to note that the Rybelsus and the oral Wegovy, while they are similar in terms of oral semaglutide, they're not exactly the same. They're not exactly the same. You can't just switch them one for one, right? If you're taking the 14 of oral semaglutide, there is no 14 of as Rybel says, there's no 14 of oral Wegovy. So there's not just a one-to-one switch. And we'll talk about that in a little bit. But that is the research being done in diabetes with Rybelsus. That's called the Pioneer trials. And then the OASIS trials were the trials that were pivotal in terms of getting oral semaglutide approved for people with obesity for weight management. And so we have OASIS 1 through 4. They're 68-week trials, so over a year-long trial. This is only in adults, right? We do have the Pioneer Teen study, which is being done with Rybelsus for teenagers with diabetes. But for now, we only have adult studies for oral Wegovy for adults. We have what they looked at as endpoints is how much weight people lost, and they also looked at cardiometabolic risk factors like changes in blood pressure, changes in cholesterol. They looked at changes in waist circumference because when you make your waist circumference smaller, that improves your cardiovascular outcomes. And they also looked at safety and tolerability. Okay, so here we're going to look at the weight loss responder rates across semaglutide and tirzepatide trials. So you might be asking yourself, if I want to lose weight, should I take semaglutide or should I take tirzepatide? Should I take oral Wegovy? Should I take injection Wegovy? Should I take injection Zepbound? Because tirzepatide is only available today as an injection. There is no approved oral version of tirzepatide. It does not get absorbed orally. You should not buy any product online that advertises that it has oral tirzepatide. It does not exist as a drug today. But we have injectables tirzepatide. So let's go through this. So here we have how much weight are people expected to lose. So this is greater than 5, 10, 15, or 20% of your weight. We have to also look at weight as it relates to a percentage. So it's not just an amount of pounds that people lose, it's the percentage of that weight from the starting point. So if you weigh 200 pounds, for example, and you want to lose 20% of your weight, that would be 40 pounds. So going from 200 pounds, losing 40 pounds, going down to 160, that would be a 20% weight loss. And with oral semaglutide, the amount of people that were able to do that is about 30%. So a third of people were able to lose that greater than 20% weight loss. Oops, sorry, it disappeared. There we go. Now we have injection semaglutide. So how does that compare to injection? Well, it's about the same. You can see here. I'm showing this to you because what we want to get across is that the injection version of semaglutide, the once a week injection or the daily pill, the amount of weight loss that people had is about the same for each one. So if you look at sort of 10%, how many patients were able to lose 10% of their weight? So lose 20 pounds if they weighed 200 pounds, for example. And in the case of oral semaglutide, about 63% of people could do that. In the case of the injection, about 69. So a little bit more patients were getting into that 10% category there, but again, about similar in terms of the amount of weight loss. Now let's look at let's look at injectable tirzepatide at 5 mg, right? How does that compare, right? Because if you're thinking, well, I want to lose 20% of my weight, right? That's what I want to lose. That's my goal. How am I most likely to get there? At 5 mg of tirzepatide, it's about the same. About 32% of people are able to get to that 20% weight loss. You can see a bit more people into the 5 and 10%, but as we get up into those higher percentages, it's just harder to lose those higher percentages is essentially the moral of the story, right? If you're wanting to lose more amounts of weight, anything greater than 15% is really hard to get to. And you can see how with tirzepatide at 15%, weight loss, there's a few more people, getting into that 15% category. And then last but not least, if we take tirzepatide up to the top dose, which is 15 mg, how many patients were able to get into that 20% weight loss category in that study? And again, these are not head-to-head trials. We don't have a head-to-head trial between oral semaglutide and injection or oral semaglutide and injection tirzepatide. We don't have that head-to-head trial. We do have a head-to-head trial between semaglutide injection and tirzepatide injection. And again, you can see at the 15 mg or top dose of Zepbound, you do get more people, about 63% now of patients are able to get into that 20% weight loss category. So as you escalate that dose, that 15 mg of injectable tirzepatide is still our most effective medication that we have on the market in terms of the chances of getting into these weight loss categories. So it really depends on what your goal is, right? As to what, are you going to be one of the 30% of people that get into the 20% weight loss with oral semaglutide? We don't know. That's the challenge, right? And so it's worth a try if what's important to you is to take an oral medication, for example, if what's important to you is maybe a cost differential, because there is a cost differential that we'll see in a second. So understanding how to make these decisions is what we do best, in obesity medicine and how we work with patients on a daily basis. Okay, so Rybelsus versus Wegovy. We talked about that a little bit. Rybelsus is the oral version of semaglutide indicated for type 2 diabetes. So that's at 3, 7, and 14 milligram tablet doses. Highest dose is 14 milligrams. Wegovy oral tablet is indicated for weight management in adults. It also is indicated for cardiovascular risk reduction in patients with known cardiovascular disease. So it does have that indication as well, same as the injection. So those two indications. It comes at 1.5, 4, 9, and 25 milligram doses. So we have a little bit different dose escalation a pattern there that's different. So what I'm trying to get across is if don't let somebody give you their 14 milligram Rybelsus if you're taking Wegovy, because it's not exactly the same thing. We've got to do a little bit of math as clinicians to help you figure out, where that fits. So oral semaglutide, I should say one more thing. I thought I had that at the bottom there. I guess I didn't. I must have taken it away. Oral Wegovy is not approved for metabolic associated steatohepatitis, which used to be called fatty liver disease. It's not approved for that. Oral Wegovy. Injectable Wegovy is approved for that. And oral Wegovy is not approved in pediatrics yet. It's not approved less than 18 years of age, but injectable Wegovy is. Injectable Wegovy is approved down to age 12. So here's our doses for oral Wegovy, the pill. Again, 1.5 milligram is the starting dose. You take that for a month. And then typically you would titrate up to the 4 milligram dose in month two, up to the 9 milligram dose in month three, and then up to the 25 milligram dose in month four and onward. And we can take that as slow or, month by month if you're not having side effects and if depending on your weight loss. But we look at these things to decide how to titrate people. The issue is, like we said, because it's so hard to absorb this large molecule, which is why it was an injection in the first place, you have to take oral Wegovy on an empty stomach. Usually, first thing in the morning is the best thing to do. You can take it at night, but you have to make sure you're taking it on an empty stomach 4 hours after eating anything. It gets a little hard at night to do that, right? Because some nights you might be going out to eat a little bit later, or maybe you went to a party or an event and you had a couple of appetizers. So again, you want to make sure best thing to do is take it first thing in the morning with less than 4 ounces of water. So just a sip of water, ideally, no food or drink or any other oral medications for 30 minutes after your dose. So you have to wait for 30 minutes. So take that sip, put it by your bedside table, put it in your mouth, take it down, and then wait for 30 minutes before you take any other medication. You also shouldn't crush or split the tablets for this reason because they need that snack to be intact to protect the molecule and protect the medication. So to get the most bang for your buck, so to speak, of the medication, you want to make sure it stays in one piece. You also need to not you need to store the tablet in its original bottle because if you take it out and put it in a pill case, for example, it can get exposed to humidity and then it can degrade it also. So it's important to keep it in its same bottle as well. And it may not be best for you if you've had bariatric surgery in the past. Again, that's because we don't know exactly what your stomach absorption is and what that looks like. And so you're probably not getting your most bang for your buck because we just don't trust that absorption that we talked about earlier with that snack when it comes to people who've had their stomach operated on, right? As far as sleeve or gastric bypass. Maybe sleeve might be a little bit better, but we just don't have any data in people that have had surgery. So probably not worth it, especially with all these steps you have to take. So let's transition and look at oral versus injectable semaglutide. So oral versus injectable Wegovy as far as side effects goes. So here you have from the OASIS trials, and the STEP trials. The STEP trials was injectable semaglutide, and the OASIS is the oral. You have the most common side effects, not all the side effects, but the most common side effects: nausea, vomiting, constipation, and diarrhea. And you can see that between the injectable semaglutide and the oral, the side effects are about the same: 47% nausea for oral, 44% for injection, 31% vomiting for the oral, and 25%, so a little bit more maybe in that vomiting category. 20% for constipation here with the oral, 23% with injection, and 18% diarrhea with the oral, and 32% with the injection. So maybe a little bit more diarrhea with the injection, right? Or a little less diarrhea with the pill, and maybe a little bit more vomiting with the pill than with the injection. So you can see that difference. And here I have the placebo. So even people on placebo, when they're given placebo, complained of nausea. So close to 20% of people in both of these trials complained of nausea at some point during the trial, right? So you can see that just because 47% of people complain, well, 20 of them percent of them were also complaining when they were on a placebo pill. So that you just puts it into some perspective as to how much more nausea those people were having. Okay, so if we just look at average weight loss, so we're not looking at, those numbers before were what are the chances of you getting that, 30% of people we said were able to lose 20% of their weight. But what is sort of the average weight loss, right? The average weight loss with oral Wegovy and injectable Wegovy are about the same. It's about 15% weight loss for each of those two medications. And again, that means about if you weigh 235 pounds, that was the average weight of people in these clinical trials, and you lose that amount of weight, that's about 33 pounds for oral Wegovy, about 35 pounds, so about the same for injectable Wegovy, and about the same for tirzepatide at 5 milligrams. So Zepbound at 5 milligrams, about the same results. You'll lose about that, somewhere around that 15% weight loss. When we look at higher doses of tirzepatide, that's where we get more up into the 19 and 20% weight loss on average for the highest dose, which is where people can get up there in that 46 and 49 pounds now if you started at a 235-pound weight loss. And that's again over the course of a year. And on oral Wegovy, and same with injectable Wegovy, that's getting up to the maximum dose. So being on 25 milligrams and staying on 25 milligrams. In fact, in a clinical trial they did in Oasis 4, they looked at in patients that were able to stay on medication and took their medication regularly, like they were supposed to, first thing in the morning, and were very, adamant about that. They were able to lose 17% body weight in those patients that were really adherent to the oral Wegovy regimen. So again, the more adherent you are in whatever medicine you're taking, the better results you tend to get, which makes sense. So here are some tips, for best results of any treatment that you're undergoing, whatever you're doing, whether it's medication or surgery or anything. Here's some tips. So we always start low and go slow. That's kind of our motto, right? I mean, start at the lowest dose, work your way up. We follow you up in our clinic once a month for the first 6 months to make sure we get through that titration period effectively. And then every 3 months after that, typically, and then stretch that out over time, of course. We adjust the dose given side effects, weight loss, nutritional intake. We don't want people running around taking a medication and feeling full all the time that they don't eat at all. That's not the intention. We want to be getting, our fiber, getting our protein in, and having that goal weight loss of anywhere from a half to 1 to 2 pounds a week, right? Depending on where you're starting from, right? What your weight is when you start from. Can also consider taking medication for nausea or other ways. You can get C-bands. Some of my patients have those C-bands. Some people use ginger to help with nausea too, because as you work through some of that nausea, it gets better, over time. And then again, for oral Wegovy in particular, you have to take those meds on an empty stomach. Wait for that 30 minutes, right? Take it with a little bit of water. Keep them, you could keep your meds at the bedside table. You want to keep them in the bottle. And it's not recommended that you take thyroid medication at the same time. So you do have to wait you wait for 30 minutes, and then you would take your thyroid medication, and then you'd have to wait for another 30 minutes before you could eat or drink, because that's thyroid medicine. You can't just double it up and take it together at the same time. You have to do that sequentially is the recommendation. And don't crush, chew, or split the tablets. Some of the alternative indications for medications such as GLP-1, Zepbound has an indication for moderate to severe sleep apnea, in addition to weight management, right? So it's a separate indication. So for some of our patients, they're able to get coverage. They don't have coverage. I put this slide here to highlight. For some patients, they don't have coverage for weight management because their insurance doesn't cover that, but they do have coverage for some of these other indications. Same with injectable Wegovy, has that cardiovascular indication, as well as an indication for MASH, which is metabolic associated steatohepatitis or fatty liver disease, that is at a F2 or F3 fibrosis stage. So if you have that, you can also sometimes get coverage by your insurance for injectable Wegovy. As well as oral Wegovy is approved for that cardiovascular secondary prevention in addition to weight management, right? This is in addition to weight management. These are the other approvals for alternative indications. And here's why I had that little bar saying that oral Wegovy is not approved for pediatrics or for MASH at this point in time. That doesn't mean it won't get approval, but at this point in time, it's not approved. You might have a question in your mind. What if I want to switch from injection Wegovy to oral? Maybe I just don't like taking injections, for whatever reason. Some of my patients like it. They'd rather take an injection once a week than take a oral medication every day, right? That's kind of me. That would be my choice. But, again, everybody has to make their own choice, right? And maybe some people would rather just take a pill every day. Well, the oral dose is essentially 10 times the Wegovy injection. So if a person was on 2.4 milligrams of Wegovy injections at a stable dose, then the 25 milligram or the top dose of the oral Wegovy would be what we would switch them to as far as, having equal efficacy, right? So same with like when you get into 1 and 1.7, if you take those times 10, that's 10 and 17. Closest number we can get to that it would be the 9 milligram oral version. And then same with 0.5 of Wegovy, or if you were on 0.5 of Ozempic, for example, wanted to switch to oral, that would be close to the 4 milligram oral dose. And then the 1.5 milligram oral is closest to the 0.25 or the starting dose, which makes sense, right? If you're looking at Zepbound versus oral Wegovy, we have these charts that exist in the world, right? This chart is not meant for you to, to necessarily memorize it or understand it, but the idea is that there are some equivalents to these medications. But the most important thing to recognize is these medications, these GLP-1 agonists, this whole class, this is all the ones listed here on this, or many of the ones listed here. So we have liraglutide, semaglutide, exenatide, dulaglutide, semaglutide, tirzepatide, right? So we have all these different tides, right? They all have these different tides at the end. So we use these sorts of things to try to help patients understand, right, what dose they might be on and how they might be able to switch if they need to switch. But they are different medications with different side effects. So you're always best, in fact, the FDA label says that we should start at the starting dose of all the medications, starting from scratch if you're switching and work your way up. That's always the safest way to do it. But for some patients who've been on medication for a long time, let's say, for example, you were on 5 of Zepbound and you lost 15% of your weight with 5 milligrams of Zepbound, and you were like, I'd like to switch to an oral medication, we would then consider switching you to the 25 milligram of the oral Wegovy. Or we might start a little bit lower just to be on the safe side, because again, it is a different medication with different side effects. So we can't predict that you're not going to have a side effect just because, it's just not one for one. Switching from Zepbound doses of higher than 5 milligrams, you are probably going to see some weight regain. So in other words, Zepbound of 5 milligrams is pretty much equal to oral Wegovy as far as its efficacy goes. But higher doses of, if you're on 15 milligrams of Zepbound and you're thinking, I'd like to switch, you may have some weight regain with that because you're switching to a medication that may have less efficacy. And again, I say may a lot because we don't know the answers to that, meaning we don't have individual people and individual responses. We know everybody responds differently to these medications. So if cost is prohibitive to you and you're thinking about switching, there's always the opportunity to try it. And then, of course, you could go back to what you're doing. But we would recommend the best course of action would be to stay with the medication you're on for the best long-term effects, certainly. So let's talk about access. So how do we get the Wegovy pill, right? So the NovoCare pharmacy has been set up as a mail order pharmacy for us to send prescriptions to as clinicians. All clinicians can send to the NovoCare pharmacy. And the cash pay, self-pay price for the Wegovy pill is now $149 per month for the lowest doses, the 1.5 milligrams and the 4 milligrams. And that's just until April 15th of 2026. After that, the 4 milligram dose is going to go up to $199. And then the 9 milligram and 25 milligrams are $299. So you have to recognize most people are going to need to go up to the 25 milligrams if you want to get that closer to that 15 or 17% weight loss, right? If you don't need that, if you only need 10% weight loss, or if you happen to be a high responder to medication, then you may respond to lower doses and be able to stay on those lower doses. But for most people, they're going to need to go up to the highest dose, and that's going to be that $299 price point. You can also send it to a local pharmacy. We can send it to CVS's and other local pharmacies of the world. And then on the Wegovy.com website, you can get a coupon, or you can text SAVE to 83757. And if you do that, you get this coupon that then you can use to get these same prices that are available at the NovoCare pharmacy. There's also that you get this same savings card, and you then can get Wegovy oral pill for a $25 copay if you have insurance coverage. So for all of these medications, if you're fortunate enough to have insurance coverage, then most of the time you get it for a $25 copay if you have coverage. And about 48% of employers today offer coverage for anti-obesity medication. And you do have to talk to your employer about it. It's your employer who decides whether you have coverage for medication. So please, talk to your employers about it and encourage them to add coverage for these important treatment options. Just to compare that, right? The Wegovy pen is currently at $349 for the highest dose of 2.4, starts at $199 per month for the first 2 doses of the 0.25 and 0.5, and then it goes up to $349 a month versus the pill, right? So equivalent dosing there. So $349 for the 2.4 milligram injection, $299 for the 25 milligram pill. That would be equivalent there. And then if you look at Zepbound vials, we have Zepbound vials on Lilly Direct, so on a separate, avenue of achieving that. On Lilly Direct, the Zepbound vials are $299 for the lowest dose, and then $399 for the 5 milligram dose, right? So the 5 milligram dose, pretty similar to the as far as efficacy to the 2.4 milligram injection Wegovy and the 25 milligram oral pill, right? So you can see the difference in pricing there for the different options. And then 449 for the 7.5 milligram vial and higher, going up to 15 milligrams at the highest dose. So 449 is that price point. The Zepbound pens, you can still get the pens today too with cash and with a coupon on the Zepbound website. And those pens then are $4.99. So to get the pens, it would be $4.99 if you have to pay cash if you no longer have coverage. And as we wrap things up, what are some other treatment options, right? So there's once daily liraglutide, which is the GLP-1 agonist you take as an injection once a day. Okay, so that's our older medication called Saxenda initially when it came on the market. It's now available generically, but the prices of it are still quite high comparably, and the efficacy is a bit lower. So with all of these older treatment options, liraglutide, phentermine topiramate, naltrexone, bupropion, those treatment options have about a 10% weight loss on average. But there are some people who get 15% of patients, for example, with phentermine topiramate will lose 20% of their weight. So there's 15% of people that will get to that 20% weight loss that they might be looking for with older medication that can cost anywhere from $30 to $100 a month instead of $299, $349. $3.99, et cetera, right? So there are cheaper ways if you are a responder to those medications and if you can qualify for those medications. The other issue is with some of these older medications, they have a little different side effect profiles. And so many people might not be able to take them because of their side effect profiles. There's also meal replacement programs. Doing meal replacement programs, these are VLCDs with having a shake or having a bar or having some sort of a meal plan that's more prescriptive. That's that purple bar in that pyramid, prescriptive nutritional interventions. Other things are like ketogenic lifestyles, when you live into a ketogenic diet, which is a very low carbohydrate diet. When you do that, those are other avenues that do produce greater weight losses. But again, you have to live with it long term and be able to live into that lifestyle in the long run. And then, of course, there's bariatric surgery. Bariatric surgery is still our most effective treatment for obesity, sitting at the top of the pyramid, because on average, it has a 20 to 40% weight loss, right? Our medicines are getting better. On average now, our medicines are between, 10 and 20%. Some of our newer medications are getting up into the 30% weight loss category as they're coming forward. So again, we're getting a little better with our pharmacotherapy, with our medication, but surgery still is the most effective treatment that we have. It is going to be proposed that Medicare potentially will be able to cover these medications for weight management in April of 2026. We do not know which Medicare plans are going to have coverage. It'll be on a rolling basis. They have to opt into this coverage plan. And these are the criteria that are going to be used by Medicare. So you'll have to have a BMI greater than or equal to 27 plus one of these conditions: prediabetes, having a heart attack, that's what MI stands for, having a cardiovascular accident or stroke. That's what CVA stands for. MASH is that metabolic associated steatohepatitis, and then symptomatic peripheral arterial disease. So that'll be a reason. If you have a BMI greater than or equal to 30, you'll have to have one of the above, those things I just mentioned, or heart failure, that's what HFpEF stands for, uncontrolled hypertension, chronic kidney disease, moderate obstructive sleep apnea, or MASH. So again, those are going to be the indications. You'll have to have a BMI greater than or equal to 35 if you don't have anything else, any of these other conditions that are listed. So again, that'll be, key to the approvals for Medicare patients moving forward as they start to get it on the plan. So Medicare patients seeking access to oral Wegovy today or in the future, if you're paying cash because maybe your Medicare plan doesn't cover it, you need to use the NovoCare pharmacy at this point in time. Medicare patients cannot use the coupons online, so you have to go through the NovoCare pharmacy. And that's at novocare.com. You can also, there at NovoCare, we can send the prescription there and they'll send you your medication. But you can also check to see if you have coverage for Wegovy. So you have this nice coverage calculator where you put in some of your information and you can see if your insurance or if maybe your insurance might cover Wegovy, either injection or oral pill. All right, in the last couple slides here, I just want to highlight why we do not use compounded peptides or compounded versions of these medications at knownwell. And that's because the FDA allows for compounding of non-generic drugs during shortages, and the shortage is over. There's no further shortage at the moment. And so again, because of that, we do not feel the safety and efficacy or the quality of these treatments in the compounded versions are enough to warrant taking that risk. There's no generic version of semaglutide or tirzepatide. There's no oral version of tirzepatide. Please do not buy oral tirzepatide from anyone. It doesn't exist as a treatment option. Novo Nordisk and Eli Lilly, who make these drugs, do not sell their FDA-approved version that have had years of research that I showed you on that timeline that have made safely and are patented molecules. They do not sell them to compounded pharmacies right now. So there's no generics. So there's no way of getting that. Anything that is starting out before it goes into the compounds are considered a knockoff. It's not the real stuff. They're not the same stuff that you're getting. Someone is replicating it and producing it and putting it into the compounded products. But again, we don't know that it's exactly the same. We can't necessarily we don't know where the production source is coming from. And so again, because of that, we don't know whether there's going to be impurities in there. And because of that, that's why the Obesity Medicine Association, the Obesity Society, the American Diabetes Association all have statements recommending against the use of compounding formulations of GLP-1 drugs because we just can't account for their safety and efficacy at this point in time, the way we have things set up. People can develop antibodies to their own GLP-1 because this is a peptide molecule you're taking. Peptides are proteins. When you put foreign proteins into your body, you can make antibodies to them. And if you make antibodies to them, then the drugs will no longer work anymore. You can do this if you don't get good stuff, if you don't get pure stuff. Novo Nordisk and Eli Lilly have worked on for decades how to develop pure good stuff from the starting point. And they look at, are we making antibodies to this during the research? And they make sure people aren't making antibodies. And because, again, then the GLP-1s won't work anymore if you make these antibodies. So that's why we feel like it's not worth the risk of taking something that you don't know exactly what's in it. At knownwell and other, we focus on comprehensive care, not just medications, but also nutrition therapy. Our dietitians help with that. Behavioral modification, our health coaches, all of us on the team help with behavioral modifications, as well as increasing physical activity, because that's also good for us in general. And then the other thing is around, referring for bariatric procedures, as well as complication management. We send people for testing for sleep apnea. We test for metabolic associated steatohepatitis. We test for, we monitor blood pressure, make sure your blood pressure doesn't go too low or too high, cholesterol management, diabetes management. Plus, we're also invested in women's health, in menopause care, and how that optimizes your weight and wellness journey, as well as men's health and how that is important as well. And the mental health piece cannot be discussed too lightly, right? Working on our mental health is important, especially today. So my lifestyle 5 Ps, if you want to memorize anything from this talk, as far as, what do I do in my lifestyle? How do I have a healthiest lifestyle as possible? These are the 5 Ps. There's actually more than 5, but I put them together. But anyway, 5 Ps, because one hand, that's how I remember things easy. Planned portions, regular, consistent eating that's portion controlled, right? Planned portions, plants and protein, right? Every time you eat your planned portions, your breakfast, your lunch, your dinner, say to yourself, am I having a protein? Am I having a plant? And if you're doing that, plants are vegetables and fruits. If you're having a protein, you're having a plant, you're doing a good job. And then power. Power stands for strength training. That's me over there in my gym in the training lab here in Weston, Massachusetts. And I'm doing my squats there. So power is for strength training. Doing some strength training is very important to maintain muscle function and muscle health, as well as muscle mass, right? And then pillow, good sleep. That's the baby there. Sleep like a baby as much as you can. If you can't, if you have trouble with that, work with us, right? That's what we do, is work with patients on this so they can optimize their results. And then pause. Avoid eating in the night, right? Having a period of time when we don't eat is good for us as well. And so again, pausing and also just being mindful and pausing from a stress reduction is very important. So those are my 5 Ps. And how can we help at knownwell? Well, we have a full team with dietitians, health coaches, clinicians that can prescribe medications other than GLP-1, but also GLP-1 medications. We have a meal replacement program that we can help patients with. We have our RX Food artificial intelligence app that helps our dietitians to really sort of hone in on, what are you eating? Are you getting enough protein? Are you getting what you need out of your nutritional plan? Frequent visits to check in for accountability, which are covered by insurance, right? With a copay. We take insurance. We don't have extra membership charges. We take your insurance, we bill your insurance, you have your copay. We also have cash pay options for those patients who might have high deductible plans and feel like they want that as an option too. So we offer 50-state virtual care, and we have 5 states where we have a clinic now. So we have clinics across the country. In Boston, we have 3 in Boston, 3 in Chicago, or a little bit more than 3 in Chicago, Dallas, Atlanta, and soon to be New York City coming very soon, as well as our 50-state virtual telehealth. We have on average about a 15% or 34-pound weight loss on average, taking all of our patients, which aren't all taking GLP-1s. So some patients are taking other older medications because that's what they can afford, or doing other types of programming. We have 50% less muscle mass loss versus benchmarks at knownwell, and that's because we really feel strongly about helping people engage in physical activity, supporting them in that, making sure they're getting enough protein in their diet, which is really how we work to maintain that muscle or that lean mass loss. 93% of our patients see sustained weight loss over the course of 2 years, the data we have today. And we have a 90 plus NPS, which is a net promoter score, meaning how patients feel about our care. And we're very proud of that. And we thank you for giving us those high marks if there's some patients out there listening. So we're trying our best in the world around us. We have a mobile app. This is what the app looks like there up in the top corner. It's got a little W, our little symbol there in the purple background. And that mobile app helps to connect to our EMR so that we can connect a little better, so you can connect a little better, do your telemedicine visits a little bit better, et cetera. And I want to put a last minute plug in to join our Peloton knownwell team. So I am a big fan of my Peloton. That's me there on my bike. I'm a biker. You might be a tread user. You might be an app user. You've got, strength routines on the app. You can walk on the app. A lot of things you can do on the app. Friend me there. My tagline or my hashtag, my handle is Be Well MD. So that's me, Be Well MD. And we have a knownwell team. So if you have the Peloton, if you have the app, join us on the knownwell team. You join the hashtag. It's hashtag knownwell. Find us there. And that way, when I'm working out, if I see you on there, I can give you a high five and we can work out together. So questions you may have, I'm going to get to the questions right now. Some things are, if I lost greater than 15% of my weight with Wegovy or Zepbound, and if I switch to oral Wegovy, what will happen? Will I keep the weight off? Will I lose more weight? Well, likely you won't lose more weight because, the oral Wegovy is pretty much equal to the injectable Wegovy as far as weight loss outcomes go. It depends on what dose of Zepbound you are on. But again, whether you'll maintain that weight is we don't have studies to show that yet. We don't have a study looking at people who lost 20 or 30% of their weight with one of these medications. If they switch over to oral, will they keep the weight off the same way they would if they stayed on their injection? We just don't have that data today to be able to say that. Will I lose the same amount of weight with oral Wegovy as injection? Yeah, from the data, it looks like the case is that's the truth, right? That the injection has the same outcome as the oral medication. But you have to take the oral medication exactly correctly every day. So the question is, how do you feel about yourself and your ability to do that, right? You have to be honest with yourself. Like, is it better for me? I just take an injection once a week? I'm probably going to be more predictable that way versus having to stay, doing that every day. Should I take oral medication or injection? That's a one-to-one, that depends on you, right? That's how we have shared decision making with our patients, deciding, what's best for them. Maybe that their mornings are not predictable, so they can't handle taking that medication on an empty stomach, and it's going to be better for them if they do a weekly injection. Should I take medication or have surgery? It's another discussion we have with our patients all the time, right? Surgery is still a very good option for patients, and we strongly encourage it for those patients that qualify and need it. And it could definitely be a part of your weight management journey. Should I take Wegovy or Zepbound? Well, that's another discussion we have, right? And that's something we can talk about, and we talk about relative to cost, especially if you don't have coverage, and relative to other side effects, and relative to what you've tried before, right? And so again, we take all these things into account to try to personalize your care and your treatment. Can I take medication, then stop it and keep the weight off? It's a very common question. Most people know. The data shows that for most people in a randomized clinical trial, over the course of a year after stopping medication, you will regain most of that weight back to where you started. That's not because you failed or because you're doing something wrong. That is because biology. Biology is helping you. The biology of the medication is helping you to get down to that weight. It is very challenging to keep weight off long term. So again, it's not something that you should feel bad about. We don't stop blood pressure medication either when people's blood pressure becomes normal. We stay on that medication in order to continue on our journey. So again, but there's not like you can't try if you want to try to come off medication and see, and then we can put you back on. But we have to make sure that we do that in a controlled fashion. So there are many choices. We take a very non-stigmatizing approach, personalized approach one-on-one with you, whether you want to be seen in person or virtually. We have a comprehensive care team that can really help optimize your long-term outcomes. We see patients frequently in follow-up, and we can see you anywhere in the US because of our 50-state virtual program, and it's covered by insurance. So we're very proud of being able to offer that type of care. And then our outcomes speak for themselves. We have a high level of remission of complications for patients, a equal to the clinical trials as far as weight loss outcomes go. We've been able to minimize muscle loss with our patients, and we think because of the care that we deliver and the frequency we see people, and we've been able to improve the function of our patients as far as their quality of life, and that's what I think makes me most happy as a clinician. So thank you so much. Here's some pictures of our care team. I like Mike's. Mike is our chief product officer who helped to build our app, and he's also very talented apparently in carving pumpkins. So he made the knownwell pumpkin this past year at the pumpkin patch. So here are we are. I'm going to get to your questions here in the last 5 minutes. I know I didn't save very much time. Let me get to these questions here. All right, Q&A. Oh, they can't hear. I know I did that. I got that. Okay. How long do I have to stop Zepbound injections to switch to Wegovy pill? Great question. I'm glad somebody asked that. We don't want you to stop necessarily. So if you're taking one of these, if you're taking injection Wegovy, or if you're taking injection Zepbound and you want to switch, you want to wait for a week after your last injection. So that last injection is going to last for a week, and then you would start your Wegovy pill. But you want to it's better if you start, you don't miss any weeks there, because if you miss doses, just like when you miss injection doses, we may have to dose titrate you down. Harder for us to decide, what dose to put you on. It's easier for us to switch you one for one if you've been on a stable dose for a while. So if you don't miss those, those doses for a long time, but not impossible. You can always start at the bottom level of the Wegovy dose and work your way up, from scratch. There's no problem there. If you've been off of your Wegovy or your Zepbound for 3 months, then you just need to start over and start from the beginning dose. But if you're on a stable dose, we can sometimes switch you to the higher dose, which just means that you're skipping some of that titration step. Okay, will knownwell be producing more of these educational webinars? Yes, thank you so much, Rick. We would definitely do them, trying to do them once a month. So that's going to be the goal. Can I take medication if I take Wegovy if I take medication for my thyroid? Yes, you just have to take it. I think I covered that question. You just have to take it 30 minutes after the Wegovy. So you take the Wegovy, you wait for 30 minutes, you take your thyroid medicine, you wait for another 30 minutes, just puts a little more time in there. What other medications contribute to obesity? There's a lot of medications that are what we call obesogenic, meaning they promote our appetite, they increase our weight, especially some of the medications for psychiatric conditions. So antipsychotic medications are traditionally known to unfortunately increase insulin resistance and increase some of that desire to eat more, which is hard to combat against sort of biologically, naturally. Other medications like insulin, for example, is weight promoting. If you have to take insulin to control your blood sugar, very important you do that for your diabetes, but it definitely can promote fat storage, and so that's a problem. Recording will be shared at some point. I'll have to find out from my team how we're going to do that, but we will have the recording available after the presentation. This person asked, they've been on the lower dose of the Wegovy at 0.5 for a long time. It continues to work. Is this okay? Yes, you can continue any dose that's working, because again, individual people respond differently to these medications. There are, if you look at even the studies of tirzepatide or Zepbound, that's considered today probably our most effective medication that we have on the market by the level of weight loss that it achieves at that 20% weight loss at that highest dose, right? Even at that highest dose, there are 5 to 10% of people that don't lose 5% of their weight. So there are people that don't lose weight, or I think it was 4% on that. If you look at if you look back on that slide of how many patients lose 5% of their weight or more, it was like 96%. So 4% of people don't lose weight on the tirzepatide. So that's not because they're doing it wrong. There's not because there's something wrong with them. It's just because they're not a responder to that treatment. And that's just the reality of our science that we have today. And that's what what we're working on continually to make it better. Um, so Yes. So the dose titration in the oral semaglutide in Oasis 4 trial is different than what was FDA approved. Okay, so there was two different types of oral semaglutide. There was the Ribelsis, which is the 3714, and then there was the oral Wegovy, which is 1.549. So it's essentially equivalent pharmacokinetically. They just reformulated it to make it so that it worked at those lower concentrations or those different doses. So the 1.4, the 4, and the 9 are essentially equal to the 3, 7, and 14. So again, it's just a reformulation of the medication. So as to be able to use less medication to get you titrated, right? Less actual drug to be able to get up to that 25 milligram, because that 25 milligram is so much more drug. So just trying to make sure that there was enough drug to go around, I guess. Um, okay, this is a great question. A question around, does the science control for weight loss when measuring the other health benefits? For example, are cardiovascular benefits independent of the weight loss, or is it likely that the cardiovascular benefits are the result of the weight loss? It's a great question, and we think that actually that the cardiovascular benefits are a relationship to not only the weight loss, but also the medication. So also the activation of GLP-1. GLP-1 activation, as we saw with that graph and all the things it does, has healthy benefits to our bodies in different ways, on our kidneys, on our heart, on our blood vessels. So it actually is probably an effect of the drug itself. And that's why, for example, some people may not want to shouldn't stop their medication because of that cardiovascular benefit, not just from the weight loss. So we know that from our cardiovascular outcome trial looking at Wegovy. Any ideas around whether the payers will cover the Wegovy oral more so than other medications or other, because it's sort of cheaper there if you look at it by cash. We don't know yet. This is the whole dilemma, right, of the pricing. And we can do a whole lecture on pricing of these medications, but it's complicated because those cash prices are not the same as the actual list price. So the list price of these medications is much higher. That's what the employers see. Unfortunately, they get a rebate on that, so they're not paying that full price. They're getting back money. So this is the challenge that we have. That a lot of reform is being worked on Capitol Hill to try to fix this issue. Yes, if you had bariatric surgery, you can get great results with these medications, but especially the injections. I was just trying to say that for the oral Wegovy in particular, we don't know that we would see the same results as we would with the injection because of the absorption of the stomach. So we're just kind of being a little more cautious about that. All right, I've gone over time. If people are still with me here, I can still answer a few more questions here. Let's see. Um, I still got some people, so stay with me. All right. Uh, teens for oral Wegovy. We don't know. It's likely that oral Ribelsis will be approved for teenagers for type 2 diabetes before oral Wegovy, but maybe then it'll have carryover and get approved that way. So there's a possibility there, but we're hoping that it comes soon. And we'll keep our fingers crossed that maybe this year that could happen. Um, if you lose a certain amount of weight, will insurance stop covering the medication? Unfortunately, that happens sometimes. We try to fight against that and do appeals and such with our prior authorizations because we don't believe in that. But sometimes that does happen, unfortunately. Is there any way to predict if I have been very tolerant to Zepbound? If I switched to the pill, would I have the same? No, there's no way to predict that. Like if you're going to have the same side effects, that's what I mentioned. Zepbound and Wegovy are different molecules. So I would say, your chances of having a side effect are probably pretty good if you switch. Like there's no way of knowing if you really need to switch because of cost or other reasons. But I think, making sure you talk to your clinician and talk about the options. That's what we do with patients every day to try to figure out, what can be the most cost-effective way to get them covered. Yeah, Zepbound in surgery, you can take those two together. I mean, we do that a lot for patients post-surgery. In terms of the injection version of these medications, we think is probably going to be better, more reliably absorbed. It's not like you couldn't take it oral Wegovy with after surgery. It's just that we just don't have faith that it's going to get absorbed as much. And if you're spending cash, I think you'd rather spend the extra $50 difference between the oral Wegovy and the injection Wegovy at the equivalent dose. So I would rather spend the extra $50 to make sure I was getting it, versus having that sort of question of, is it going to get absorbed? We wouldn't be able to tell if you weren't responding because you weren't responding to the dose, or if you weren't responding because you weren't getting it absorbed. That would be the hard part. All right, how come oral Wegovy has the cardiovascular indication but not the MASH indication? That's a good question, and that's because of the MASH indication for injection Wegovy coming later, and because of the oral Wegovy got approval for the cardiovascular indication via some of the other trials that have been done with oral semaglutide for diabetes. So there was some overlap there. Yeah, someone said they expected their insurance to stop paying for their medication and they got a refill in January, it was still covered. Maybe you're good. I don't know. It's good. It's always good to see what happens. Does traditional Medicare, not Part D, cover Zepbound? Well, traditional Medicare will cover Zepbound for sleep apnea usually, not always. It depends on the plan, right? So it just depends on what plan you have. And then it also depends on, again, those Medicare plans are going to start to pick up these coverage for these treatments starting in April on a variable basis, right? It'll be up to the individual plan. Like if you have Blue Cross Blue Shield Medicare supplement for your Part D, then they'll have to pick that up in order to have that covered. Oh, we got so many questions. I wish I could answer them all. I'm trying to scroll through. Is moderate coronary artery disease considered a cardiovascular condition for getting coverage approved through Medicare? Great question. Depends on your plan. Again, some plans will be okay with that. We think it's great. I mean, that would be a reason. That's a good reason to be on it. Don't get me wrong. But for some of them, they're very strict about the fact that you have to have had a myocardial infarction. So you have to have had a heart attack, which is ridiculous because you don't want to have a heart attack. So like even if you caught your disease before you had a heart attack, right? Some of them are very picky about that, but we try our best. That's all we can do. All right. Well, you guys have so many questions. And let me see if there's one more last one I can do on the way out here. So this is a good question. Are there frequent drug interactions with Wegovy and other meds? No, that's the good thing about these GLP-1 agonists. There's not a lot of drug-drug interactions. There's not a lot of reasons why people, can't take them. One of the biggest reasons is if you have a history of medullary thyroid carcinoma, because for all GLP-1 agonists, everything in the class, in that early days of research, back on that graph, when they first gave these types of medications to rats, the rats got medullary thyroid cancer. Because of the rat data, we take an abundance of caution because we don't know how the rat data compares to human data because we haven't seen any human medullary thyroid carcinoma, any increase in medullary thyroid carcinoma in humans. They've looked at that retrospectively and haven't seen that same increase in medullary thyroid carcinoma in humans. But in the rats, because of that, if you have a history of medullary thyroid carcinoma, we think it might be too much risk for you to take one of these medications. Now, that being said, that does not count for other thyroid cancers. So it's only medullary thyroid carcinoma that has the black box warning for. But other than that, if you have liver issues, you have kidney issues, you can take these medications, which is good. They don't have a lot of interactions with other medications or other treatments. All right. So somebody mentioned the ease of airport transportation of injectable versus taking an oral. Like another reason they might take an oral medication would be it's easier to travel with. I would just caution that a little bit because it is pretty easy to travel. You don't have to keep Zepbound as well as Wegovy injections, you do not have to keep them cold all the time. So they are stable at room temperature. They are stable at room temperature for over a month. So you can keep them at room temperature. You shouldn't, like if you're going to go in the Sahara and go on Odyssey or something, you're going to have to keep them cold, right? But like if you're just traveling to, wherever, Florida or something on the airplane, they're totally fine to take through security. Security doesn't give you a hard time at all. At least they haven't for me for decades. But they you take them through security, you put them on the airplane with you, you keep them at room temperature, totally fine. You shouldn't leave them in the hot car, like when you get there, but just put them in your backpack, take them into the restaurant or wherever you're going, and they're fine at room temperature. So you can travel pretty easily with these injectable pens. But that being said, pills probably are a little bit easier for people who travel a lot. All right. Well, you all have had been great to stick around with me and answer all these questions. I'm sorry if I didn't get to all your questions. I was been trying to work through them here and see. Um, so one last question. I got to get this one. Can I be a no-no patient if I want support to maintain my weight loss and not regain weight? Yes, we take all patients. In fact, you don't even have to want to lose weight to come to knownwell. We'll take anybody, meaning we see patients, for all sorts of conditions. We see patients for primary care. We see patients for weight management. And so please, if you want to be a knownwell patient, I should have said you can go on to the website. You can register as a new patient. That's knownwell.co right there. You can register as a new patient. You can book your first appointment, and you can do that all online at the website. So thank you so much for all of you that have stuck around today on this snowy evening. And I look forward to our next In the Know. And maybe what we'll do is we'll keep all these questions, and then maybe we can just have one in the know of everybody's questions, and we can that'd be a good one too. So take care, be well, and we'll see you around.